Good morning, and welcome back to my corner of the multiverse. You are listening to the Salty Goddess podcast, and I'm Margaret. Please be certain to follow, share, subscribe, and download every single week, and follow me on all my social media accounts. Gotta get those numbers. You know how it works. So let's get right into what we're going to talk about today. You and I once believed in Santa and the Tooth Fairy, the Easter Bunny, the Boogeyman, maybe even Godzilla. And one day you received new information, maybe from a classmate, a sibling, a cousin, a neighbor. You updated your belief system, and somehow you survived the devastation. So I'm curious as to why, in 2026, there are clinicians that behave as if new evidence is a personal attack on them or it can't be trusted. This episode is not about whether you are allowed to have beliefs. Of course you are. We're all human. We're all individuals. We all come from different places. This episode is about whether you are allowed to drag your belief system onto a scene, into an ambulance, into an exam room, or anywhere else that you are caring for a patient, their home, whatever. And use your belief system to gauge who gets compassion and who doesn't, who gets evidence-based care, and who you're going to treat as if they are a moral inconvenience. The dilemma is not that a clinician has a belief. The dilemma is when, as a clinician, you allow your personal, political, cultural, generational, religious, or outdated educational beliefs to override current evidence, accepted standards, and our duty to treat the patient ethically at all times. Medicine, it's not a reward system. We don't treat people because we approve of their life story. We're there to treat people because they have a need and they are our patients. Things like pregnancy complications, substance use disorder, obesity, HIV, STIs, STDs, gender-affirming care, chronic pain, mental health, reproductive care, diabetes, lung disease, any situation where a clinician starts with, well, they chose this. You're literally saying that you believe a patient has chosen what has gone on, and you stop assessing the patient's need for medical care and begin sentencing them. That's kind of wild to me. Sometimes it's surrounding a specific diagnosis. Maybe lung cancer and the smoker. Well, they chose to smoke. So, diabetes. Well, they choose to overeat and be overweight. Oh, okay, does that change the fact that they have an issue? No, it doesn't. So the second that you reduce that patient to saying they chose this, you have stopped assessing the patient, and that's what you're there for. And I am not here to point fingers at any one particular medical profession or level of clinical licensing. I've seen it through all of them. You are no longer assessing this patient. You are passing judgment. You are judge, jury, and technically executioner. That sounds really, really, really damning if you ask me. All right. Ethics guidance says that clinicians have duties to not discriminate against patients based on personal or social characteristics that are not clinically relevant. It does not matter how they got there. It's that they're there. Choosing or not choosing it's not clinically relevant. We're supposed to practice medicine with compassion and respect for the inherent dignity, worth, and unique attributes of every single patient. Discrimination in healthcare is a patient safety concern, not just a politeness issue. Your feelings are not irrelevant, but they're also not in charge. Your discomfort, your unhappiness, your rage does not outrank the patient's diagnosis. Your belief does not outrank their right to appropriate care. And your moral squinting is not prescribing authority. And let me give you an analogy here. It's 40 years ago or more. Many patients with asthma were treated primarily with albuterol or other agents that would cause bronchodilation. Okay, so we treated primarily bronchoconstriction because that was the problem, right? We opened the airway. We rescued them from the wheeze. Here's your albuterol. Off you go. However, today, we understand asthma as more than just bronchospasm. Bronchoconstriction is an effect of other things going on in the body. If we stop those other cascading events, they have less of a need for reliance on a bronchodilation agent, which is good because only giving them something to dilate the bronchi was killing patients, believe it or not. So we understand that asthma involves airway inflammation and hyperresponsiveness, excessive mucus production, exacerbation risks, triggers, and long-term control. So today, modern, updated, evidence-based, new information says that anti-inflammatory therapy is at the center of airway management and asthma management, not albuterol. We use drugs that are called like low-dose ICS, Vamorolol preferred as a reliever therapy for many adults and adolescents because it reduces severe exacerbation risk. So if we can update asthma care when the evidence changes, why can't we update our judgment when the evidence changes for other disease processes? Why is the inhaler allowed to evolve out of our mainstay therapy, but for other medical issues, our biases get grandfathered in like medical heirloom from a cave wall or some crap like that? It's not cool. I mean, by that token, when you use the idea, the false comfort of, well, they chose this. Well, your mom chose to have you. Should we go to her and say, we don't like your child, so we're not going to treat you because you chose to have this child. They've turned out to be a jackhole, so we're not gonna treat you because of our personal feelings about your offspring. Doesn't that sound kind of crazy to you right now? Because it should. When people they chose this substance use disorder when they chose to take a drug. That is a lazy substitute for clinical reasoning. Even when behavior is part of the clinical picture, behavior is not the entire human being. There's genetics, trauma, poverty, abuse, education or lack thereof, access or lack thereof, food deserts, untreated mental illness, chronic stress, adverse childhood experiences. There's neurobiology, social conditioning, family systems, medical misinformation, prior medical harm. The list goes on. Plain old human survival all shape that patient. And you want to put your finger on a moment in time and say that is the crux of their problem without taking anything else into consideration. Those social determinants of health, where there's a dashboard on a government website that can predict how long you will live depending on where you live. Think about that. Where you live should not decide whether you live or whether you die. Bono said that in a song. It's one of his lyrics. Think about that. The government knows that your zip code can predict your life expectancy. That's wild, but you want to believe that it was a choice. You know so much more than everyone else. You've got the corner market on knowledge, don't you? You think that you've met someone for 20 minutes? You get to skim the worst chapter of their life as you've seen it and declare yourself qualified to judge the whole damn book. Tell you what, I got a couple chapters in my life I wouldn't want somebody reading and rereading and, skimming and then making a decision about my person as a in totality. That's wild, because I'll bet I can look at a couple of your chapters and think, this guy's got, or woman, this person has got really poor judgment skills. Okay? 20 minutes hearing one piece of information, seeing one moment on a timeline does not give you the full picture. Not in a million years. I'm telling you. You sure as hell would not want someone to do that to your loved one, your family member, your mom, your dad, or even you. So, is it clinical judgment when someone isn't using any clinical acumen, clinical assessment, clinical data? Or is it cruelty? To me, it's cruelty. Absolute cruelty. All right? And I want y'all to know, this is not an attack on your faith. This is an attack on using faith or belief systems as a weapon in clinical care. This is not an attack on your personal values. This is not an attack on your morality or your moral values or your standards. This is an attack on substituting your personal values, your moral convictions for evidence-based practice, for science. Your belief belongs to you. The clinical guideline for that disease process belongs to the patient who has the disease. So your belief, your standards, those must be recognized and managed. You have every right to believe what you believe. It ends there, though. Your belief should not impact how a patient is treated. And I've used this in other courses when I've taught. And I kind of, joke about some things. But when you refuse to follow clinically set guidelines and evidence-based practice, data and research and treatment guidelines, and that is harmful to the patient, it's not noble. Refusing to do or to care for a patient because you believe it was a choice is not ethical. So I'll go back to what I was going to say before. I joke a little bit about Ford drivers and things like that, and how I know that if you drive a Ford, you've got poor judgment skills. But when I arrive at your house and I see that you have 4 Fords in your driveway and none of them work, I understand why you called for an ambulance. I understand why you had to, seek some medical attention. The important thing is that when I get to your bedside to care for you, I am going to behave as if you drive a Chevrolet. My personal bias, feelings, preferences, beliefs, do not belong at the bedside with a patient. Or, and I don't care if, when I say bedside, just so y'all know, I'm talking about their home, the scene of a 911 call, the emergency room, the exam room in a clinic, the exam room in a doctor's office. I don't care where it is that you are providing medical care. But your biases do not belong in medicine. Your knowledge, science, evidence-based practice belongs with you and that patient. Period. And there is no way to negotiate that or to deviate from that. All right? Conscience guidance is useful. Okay? It's important. But when your conscience guidance imposes your beliefs on a patient, it affects patient health. It threatens scientific integrity, and it creates discrimination. And I think it's great that you have a conscience. Congratulations. Your patient also has a conscience. And unlike yours, theirs is attached to the body receiving the consequences. Okay? If you cannot treat patients whose choices, bodies, histories, identities, religions, reproductive history, addictions, diagnoses, or life circumstances make you uncomfortable, the question is not whether this patient deserves care. The real question is whether or not you belong in the room at the bedside. Because at the end of the day, medicine is not about, quote unquote, liking every single patient. Medicine is about competence, ethics, compassion, boundaries, and duty. And if your compassion requires the patient to pass a purity test, if you will, that's not compassion. That's ego in a uniform. Let that sink in for a moment. What you deny for others, you would demand for yourself. Another Bono line, by the way, out of another song. You would not want someone to look at you and say, you chose this, so you won't get any compassion from me. You won't get any empathy from me. You did it to yourself. How would you feel if someone else used their own personal beliefs and not clinical judgment to determine whether or not they would give you empathy and compassion? You wouldn't like it. You'd say something about it. You'd get loud about it. I know you would, because I would. At the bedside with your patient, they deserve the latest evidence-based guidelines, and they deserve compassion and empathy. We cannot possibly know what path, what lived experience this patient has had. We cannot take them and post them against us and say, well, I could handle that. Why can't they? Because each and every single person has differing strengths, abilities, coping mechanisms, and, dare I say, comorbidities. Someone who's been abused in the past, someone who's had poor nutrition in the past, someone who was never taught to cook or to understand the importance of, not overeating or eating heavily processed, chemically laden foods. How can you say, well, I eat right? Good. Well, good for you. Okay. Get your moral high horse off of the scene, out of the trauma bay, out of the exam room, out of triage, and out of the ambulance. It's just not where it belongs. So, before judging your patient, ask yourself this: is this belief that I have clinically relevant? Or is this a personal reaction? Am I applying this standard to a patient the same way that I would apply it to someone I know and I love? Have I brought myself current on the evidence? Or am I practicing clinically from outdated education? That's a really good question. If you haven't gone and received updated information, I want you to just think about this for one moment, just for one moment. If there is nothing else that tells you that research and data can either support what we're presently doing or tell us to do something different, you just need to look at one place, and that's the American Heart Association. That is ILCOR, the international liaison that helps to do the data studies and the analysis, not the studies, but and analyzes the data that tells us every 5 years what we should change, what we shouldn't change, and what is comme c'est, comme ça, either or, do it or don't. Every 5 years, my friends, every 5 years. So are you current on the evidence of substance use disorder, mental hygiene, sexually transmitted diseases, etc.? If you're not, you might want to start looking into it. National Institutes of Health have a ton of information, ton of studies. Your medical director, loads and loads and loads of information. Ask yourself this question: would I document this judgment in the chart? Last time I heard, you document the facts. not emotion. Mm-hmm. If you were asked to sit in front of your certifying or licensing board, would you tell them, this is the reason I chose to speak to the patient the way I did, to do the things that I did? Ask yourself whether or not your discomfort because of your belief system is causing a delay in care, a dismissal of the patient's chief complaints. Is it causing me to undertreat or even refuse to treat this patient's medical condition? Have you offered appropriate care, appropriate referral, appropriate transfer, or even escalation? Because if you wouldn't chart it, if you can't defend it, if you would never teach it to someone or want it done to yourself or your own family, maybe you don't do it to someone else. I mean, that sounds kind of wild, doesn't it? So, new evidence is not an insult. It's an invitation to improve your clinical skills and practice and to give better care to your patients. We've all survived learning that Santa was not real. We survived learning that asthma care needed more than rescue bronchodilation. We survived updating wound care, sepsis care, cardiac care, trauma care, mental health care, addiction medicine, reproductive medicine, and every other field of medicine that has the audacity, if I dare say so, to evolve. So no, friends, you do not get to freeze your clinical ethics in whatever year your prejudice or belief system or standards or moral convictions felt the most comfortable. Patients do not come to us for us to morally grade them. They come to us for help in some of their most dark moments. They come to us to be cared for. And if you cannot tell that difference, maybe stepping away from a clinical role should take place before your bias becomes someone else's harm. Okay? And again, I'm not attacking your belief system. I'm attacking the misuse of belief for clinical care. Everybody knows we have values. Just make sure you're not using those values as a weapon against a patient. Okay? Let people's behaviors wear their shame. Okay? It's not for us to decide. All right? I do not like working alongside clinicians that practice with troglodyte energy or providers that drag fossilized bias into modern medicine. Your personal belief system is not a clinical guideline. Medicine is not a reward system. Okay? New evidence is not meant to insult you. It's an invitation to know better, do better, be better. Period. Outdated education is not a personality trait. Update your practice knowledge. Plain and simple. All right. I hope that I've been able to reach out to some of you who have been having difficulty with this, you have to silo your beliefs, your moral convictions, and only engage clinical practice guidelines that are evidence-based. That is what medicine is all about. That is what the Hippocratic Oath is all about. And it also supports do unto others as you would have them do unto you. I want to thank you all for joining me for your Hump Day Guilty Pleasure here at the Salty Goddess Podcast. I'm Margaret, your hostess, of course. Be sure to follow, share, subscribe, download. Get onto that social media and let everybody know how much you enjoy this podcast. Thanks for listening, and I look forward to hearing or seeing y'all next week when we do our next drop. Thank you.